Lupus anticoagulant, simple word, reported as detected or not detected, like what Dr. Priya said. I do not like to, encourage any test which is mildly detected, moderately detected, and highly detected. Such results have to be crushed and put into the dustbin. So it should be reported either as negative or not detected, detected or not detected. So this is a result which came from Apollo. It's got strong lupus anticoagulants detected in this patient with obstetric APS. Then this is another report which shows, you see, the anti-beta 2 glycoprotein is 16.2 and the cutoff point is less than 10. You see the anti-cardiolipin antibody, my God, it's 60.3 and the cutoff point is less than 40. So what I'm telling you is, do all the 3 tests, do it in the fasting state, and there are levels which are available. Lupus anticoagulant report is detected or not detected. That's very, very important. Now, the other important point as far as diagnosis is concerned, she already told the Sapporo criteria, in which you should have 1 clinical plus 1 laboratory, which even Lord Krishna agrees with Ramakrishna. Clinical criteria for the diagnosis of OAPS, I need not talk to obstetricians, and Priya has already told you it will be more than 3 consecutive miscarriages less than 10 weeks, or 1 unexplained death of a morphologically normal fetus after 10 weeks, or 1 premature birth less than 34 weeks gestation due to preeclampsia. One important quality of a obstetric antiphospholipid syndrome with respect to preeclampsia, it is early onset preeclampsia less than 34 weeks of pregnancy. That's an important point. We should keep it in your mind. So laboratory test, what it said, 1 or 3 of the laboratory tests should be positive at least on 2 or more occasions at 12 weeks apart. So to just run through the antiphospholipid syndrome, it's an acquired thrombophilic state, it's an acquired autoimmune inflammatory state. It is an autoimmune disease. It can be primary APS, it can be secondary APS. Pathogenesis is just not thrombogenic, but it can also be inflammatory. The placenta is a major problem as far as obstetric APS is concerned. Tests, we have 3, lupus anticoagulant, anticardiolipin antibody, and antibody to beta 2 glycoprotein 1. You have a clinical criteria and you have a laboratory criteria, and 1 clinical and 1 lab has to be fulfilled to make a diagnosis of obstetric APS. Now, what about laboratory tests? Now, what happens is, we are in an era of laboratory medicine where most of us even do not see the patient. Clinical medicine is dead, especially in these virtual days of COVID telemedicine and teleconsultation, which has become virtual. We have forgotten how to even examine the radial pulse. We write laboratory tests. So in such situations, if you do laboratory tests without seeing the patient, it is like giving a consent for your marriage without seeing the life partner. Just imagine what may happen on the day of marriage. On the day of marriage, your life partner may belong to the same species or may belong to another species. And then what happens is, your horoscope becomes our horoscope. Even whether you see a life partner and get married also, your life is only a horoscope. But what I would tell you is, please do not order any laboratory test without seeing the patient. You have to come to a clinical provisional diagnosis and order the test tailored to the needs of a diagnosis, and write not all the tests and say, okay, do everything. Something will be abnormal in all of us. I like to tell you one important point. In my 37 years of practice, I've never found a normal person in my life, including my own self. Somebody is an obstetrician, sees many people with pregnancies. Do we do the antiphospholipid antibody test in everybody who comes to us? It is absolutely meaningless. Unless they have an adverse pregnancy event in the past, you should not order a test for antiphospholipid antibody. That's very important. It's like Hamlet, Shakespeare, to be or not to be, to do or not to do. Do not do it indiscriminately in everybody. All patients with systemic lupus should have the test done for APL. Now you can ask me, Dr. Ramakrishnan, you told me that I should not do it for everybody. For whom else I can do? You do it in patients with recurrent pregnancy loss. 7 to 10% of patients with RPL have antiphospholipid antibody syndrome, which is a treatable condition. Unexplained IUDs and IUGRs. I said pre-eclampsia before 34 weeks of pregnancy. If there is a maternal history of a vascular thrombosis prior to a pregnancy, whether she had a deep vein thrombosis, all patients with systemic lupus it is mandatory that you do the 3 tests for antiphospholipid antibodies. That is very, very important in SLE patients. So we first defined what was APS. We talked about the laboratory test. We spoke about the pathogenesis. And then we spoke about the criteria. Then after that, we come down to the when to do the antiphospholipid testing. Now we come to the management. The management of obstetric APS is a multidisciplinary team. It is the holistic approach to a patient. The patient is psychologically very disturbed because he's had multiple pregnancy losses. Psychologically very, very disturbed. Psychosocial support may be poor. Investigations are costly. Treatment is costly. So the patient actually comes to us in a very disturbed state. In addition to giving tender, loving care, we have to give scientific treatment. And so we have to give an Indian team around, like what is the Indian World Ladies team which won the World Cup. That's important. Now, whenever a person comes to you with a diagnosis of obstetric APS, I, as a physician, will sit at my consultation table and I will write down all this. What is the risk stratification? Who are the people who are at greater risk to develop OAPS syndrome, multiple pregnancy loss? Presence of SLE, history of maternal thrombosis, previous history of fetal loss, presence of hypertension, presence of dyslipidemia. So if any of them is present, it means the risk is very, very high. Then you come down to lab stratification. This is very important, jot it down, or even take a photograph. Risk stratification in OAPS is triple positivity. That is positive for 3 antibodies. Lupus anticoagulant as a single positive test also will say that this person is running into trouble. High titers of both IgG, HCl and IgG beta-2 glycoprotein 1 are high, are a great risk. So triple positivity, presence of lupus anticoagulant, high titers detected by ELISA, which means that the prognosis is not good. And this is going to be an eventful pregnancy and you've got to have high surveillance about it.